All right, I think we will go ahead and get started. So good morning, everybody. I just would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. So first of all, if any of you are sitting in classroom D wondering where we are, we've had to change venues because of some technical issues. We are hoping to be back there, but for now, we're in back again in CSB. And also, I just want to take this opportunity to wish all of my female colleagues in the department and across the campus happy International Women's Day, which is tomorrow. And with that, I'm going to hand it over to Dr. Gopi Pratendra, who is going to introduce our speaker today.
Thank you, Norman. So it is with great pleasure today that I introduce our guest speaker, Dr. Mike Paulden. And so Dr. Paulden, he grew up in the UK. He did his master's in York.
Yeah.
And then he came here to the University of Toronto, where he did a research associate there. Then he came and did his PhD actually here in the Department of Medicine, before taking on a faculty position in the School of Public Health. And I just want to, and so Dr. Paulden is now, he's an associate professor in the School of Public Health, and he's a health economist with an interest in methods for economic evaluation of medicine and other technologies. He has provided expert advice to policymakers and health technology assessment agencies around the world, including Canada's Drug Agency and the Patented Medicines Prices Review Board, the Canada's federal price regulator. And so the reason we invited Dr. Paulden to give a lecture here is because his work is really relevant to a lot of the work our basic scientists do and our clinicians do. For example, basic scientists, they really need to know if they're working on a drug, the impact that drug will have, whether it will actually even be able to make it towards a trial or towards being FDA approved in practice. Because if the economics aren't there, it won't be funded. And the same with a lot of the drugs that we run in our clinical trials. If the drugs don't have a fair economic valuation, there's a good chance they won't make it. So this is really important for a lot of what we do in our department. And so that's why we thought it was very important to have Dr. Paulden here to share his experiences. So thanks.
Thanks so much. Yeah, thanks very much for the invitation. Fantastic to be here. So today I'm going to present on a paper that was published about a year ago, but it's a paper which I'm continuing to build upon. I'm actually taking a sabbatical in a few months for a year, and I'm going to be traveling around the world working with groups who are interested in this space, who are doing further work here. So this is a framework that I'm hoping to expand upon over the coming years. So just before I begin, conflicts of interest. So I don't have any financial, professional, personal interest in the price of medicines. I have no relationships whatsoever with the pharmaceutical industry. I don't do any consulting or anything like that. I have provided expert advice to public bodies. So the federal government in Canada, I chaired a working group for them a number of years ago when they were looking at revising how patented medicines are regulated in Canada. That was about 8 years ago. They changed the regulations, so I was involved with that. And I've also done work with Canada's Drug Agency and also similar public bodies in other countries, such as the UK and New Zealand. There are public bodies which are interested in how we price medicines, and they attempt to negotiate reasonable prices for medicines. And so those are my conflicts of interest. This is the paper. If any of you are interested, it's been published. It is open access, so you can all download that from anywhere in the world. You don't need library access to get this. So it's in Pharmacoeconomics, which is one of the leading journals in health economic evaluation. So I've been told that we need to keep to time because there's another class coming in. So I'm going to try and keep my presentation to about 30 minutes, 35 minutes to allow some time for questions. So this is really a condensed version of the paper. The paper is quite substantial. I'm just going to focus on a few things which I think are important that come out of this that I think would be interesting to you. So there's two primary considerations that I think of when we come to pricing medicines. How do we determine a fair price? So the first consideration is something that won't come as a surprise to any of you. Public healthcare budgets are constrained, right? We saw that during the pandemic, and we've seen it even more clearly since the pandemic. So what does that mean? As a health economist, how do I think about a constrained budget for our public health system? So when you've got a constrained budget for the system, imagine that there is a new medicine that you would like to reimburse from the public health system through one of our public drug plans, right? We want to reimburse this medicine. And usually, not always, but usually new medicines cost more than their comparators, right? Usually it involves handing over more dollars than we're currently spending. Not always, but usually. We can talk about some exceptions. But why do we do it? Why are we willing to fork out more dollars for these new medicines than what we're doing now? Because usually they provide better health outcomes than the treatments that came before them, okay? So we're paying more dollars from our budget, but we're getting some expected health improvements, okay? Now, where health economists come into this is that we look at that constrained budget, we see the dollars flowing out of it, and we think, hang on a minute, those dollars need to come from somewhere. So for any given budget, if dollars are being spent on one activity, they now cannot be spent on another activity that would be of value to patients, right? So there will be less funding for something. Maybe there's now longer waiting lists, right? We could have used those dollars to shorten hospital wait times. We're not doing it. We're using those dollars for a new medicine. It might be the benefits from the medicine are greater, but nevertheless, we have lost that opportunity to spend those dollars reducing hospital waiting times. In very rare cases, there could be delisting. That's quite uncommon in Canada. But there's other investment opportunities foregone. And I've had this conversation with many, many decision makers, and we've talked about, well, what if we can do some disinvestment? What if there's some inefficiencies we can find to get the dollars to pay for the new medicine? Does that avoid this foregone health? And the answer is no, because even if you can do a disinvestment, even if you can find the money down the back of the couch, you could spend those dollars on other investment opportunities. You could use those dollars to expand primary care access, right? So when you use, even if it's new money, if you use it for one purpose, you can't use it for another purpose that is of value to patients. And by spending less on other things, by spending less on other things, just before I come to that, what are the examples? Here's an article from December 2023, Canadians dying while on medical wait lists, which is 5-year high. None of this is new to you, so I'm not going to go over this. You all know about the crisis that we have around waiting lists. As bad as we've seen it in 25 years from the AMA president back in December 2023. Not just Alberta, of course, it's across Canada. This is Ontario hospitals dealing with long wait times. And I'm sure many of you saw this survey in 2023, published in the CMAJ, that highlighted worsening primary care access. One thing that was really noticeable from this survey, this is a direct quote from the paper, more than 1 in 5 Canadians, an estimated 6.5 million people, do not have a family physician or a nurse practitioner they see regularly. And that's a dramatic increase since before the pandemic. Okay, so there's 1 in 5 Canadians who don't have a GP, they don't have a nurse practitioner. So think about the benefits that would come from spending additional dollars on expanding primary care access, right? Every dollar that you spend on a medicine is a dollar you cannot spend expanding primary care, reducing hospital wait times, okay? So there are these losses that arise when we spend dollars on one activity and not on something else. The question, of course, is whether those health improvements are greater than the expected health losses. So I'm not at all saying you shouldn't spend the money on new medicine. What I'm saying is look at the benefits from spending money on the new medicine, and then look at what we call the opportunity cost. Look at the benefits you would get if you spent it on other things like reducing waiting lists, expanding primary care. And that is what health economists do, right? We do economic evaluations for Canada's drug agency, for other agencies in other countries. And at the heart of these economic evaluations, when you strip away all of the math and all the complex modeling, when you strip that away, what are we doing? We're trying to estimate the health improvements from paying for this new medicine and the expected health losses as a result of the cost of this medicine. And when we do these economic evaluations, we usually adopt something called a publicly funded health system perspective. I'm not going to get into too much detail about that now, but essentially what it says is all we're interested in this economic evaluation are the costs that fall on the health system budget and the health outcomes that we get as a result of paying for this medicine and the health outcomes that we forego as a result of paying for this medicine. That's all we're interested in. There is a bit of a push at the moment to expand this perspective to consider what we call societal benefits, productivity losses, you name it. We can talk about that after the slides if anyone's interested in the implications, because it's quite complicated. It's nuanced what the implications would be of that. But under this perspective, which is the default perspective that many HTA, health technology assessment organizations, adopt, the focus of the economic evaluation is population health, right? We don't consider productivity. We don't consider other outcomes. And this is really quite important because it means that if we consider a technology to be cost effective, it's because we expect it to improve the health of the population. And if we think it's not cost effective, then it's because even if the medicine's effective, the cost is so great that we could get even greater health benefits from spending the money elsewhere, right? That's what we mean when we say something is not cost effective. So imagine there's a new medicine and it provides health improvements. And if we price it at a low price, then that's going to minimize those health losses elsewhere. So at a low price, reimbursing an effective medicine will improve the overall health of the population. But the same medicine at a high price would result in a greater expected health loss. And if that exceeds the expected health gain, then we would consider that not to be cost effective because it diminishes the expected health of the population. Okay, so that's the way that as a health economist, we think about whether drugs are cost effective or not. It's about the impacts on population health. Okay, what's the second consideration? And this is really important. New medicines are expensive to develop. And there is some controversy around just how expensive they are to develop. This is an article that was published in 2020 that tried to estimate the research and development invested needed to bring a new medicine to market. This is a quote from that article. You can see that, you know, after accounting for the cost of failed trials, the median capitalized research and development investment is over $1 billion, right? The mean is about $1.5 billion, right? So drugs are expensive, right? Even if you disagree with these numbers and you cite a different study, no one would say that developing a new medicine, going through all of the trials, going through regulatory approval is not expensive. It is, it's expensive and it's risky, okay? So the way in which my framework begins, the starting point for this framework, is to just recognize two things. The first is that if the price is too high, then it could diminish the health, diminish the health of the population. If the price is too low, then it's not profitable. And you can't expect people to develop medicines and launch them if it's not profitable. So the starting point for my framework is a proposal that a fair price is one that is low enough that reimbursing the medicine is expected to improve population health, but it's high enough that the medicine is expected to be profitable for the manufacturer. That's the starting point. We're going to go into a bit more detail here, but that's the starting point. So just while I have some water here, just for a minute here, does anyone have any further thoughts about that? Do you agree with this definition? Are there any other considerations? I'm going to talk about more considerations, but at this point, any considerations that you think should be taken into account? Yes, go ahead. Mm. Oh, yeah. Yeah.
Somewhere in the brain.
Yeah. Yeah.
So if you're not in hospital, you pay for your own.
Yeah.
Or
yeah. Yeah.
Yeah. In hospital.
Yes. Yeah.
So I think
yeah. Yeah. So I don't know if everyone heard that online, but absolutely, it's not necessarily. Yeah. Did everyone hear? I can repeat it. So not every medicine is covered under the public system, certainly here in Alberta. So it depends on the jurisdiction. In some countries, like I grew up in the UK, so there's much greater coverage of medicines. People do have to pay a small prescription fee, but there's much better out-of-hospital coverage of medicines in the UK. And then there's also the fact that the sort of the personal element here, right? That you know, if you're a clinician and there's a new medicine comes along for your patient, okay, your priority is to treat the patient in front of you, okay? And this is something that's at the heart of this, that there's, you know, it's so difficult if you're a clinician to be told, well, you know, we're not going to reimburse this, right? I mean, it makes absolute sense for a patient who has a disease and there's a new treatment to advocate for access to that medicine, and for their clinician to advocate for access to that medicine. At the same time, if the price is extremely high, then there's that public policy element of, well, hang on a moment, we could actually use those same dollars to create more health, to improve the health of the population by more. So there's inevitably that tension. And I can tell you that politically, approving these medicines at high prices is a lot easier than rejecting medicines at high prices. Because when you reject a medicine that's at a very high price, those who lose out as a result know they've lost out. They know, hey, that's a medicine that would treat me, and Alberta is not paying for it, but another province is, or the US is paying for it, right? If you have, but think I said a moment ago, if we pay for these medicines, there's an opportunity cost, right? We can't spend the money reducing waiting lists. If you bore the consequence of that, would you know it? If you were put on a waiting list of 6 months, would you know that it would have been 5 months if only we hadn't paid for that expensive medicine last year? You wouldn't know about it. So politically, there's always that sort of incentive, if you like, to actually approve medicines, because yeah, there's the patients who receive them that in practice get the loudest voice actually in this process. Okay, so I'm going to move on. So the framework that I published considers pricing medicines in 2 different ways. The first is pricing medicine independently. We're going to consider each medicine on its own merits. What is a fair price for that medicine? And then in the second part of it, I talk about pricing medicines collectively, because in practice, what happens is that agencies like Canada's Drug Agency in Canada, the National Institute for Health and Care Excellence in the UK, they will publish or they will have, either implicitly or explicitly in the case of the UK, they will have a willingness to pay for a new medicine. They will say, we are willing to pay up to £30,000 per quality adjusted life year for a new medicine. Other agencies in Canada, they might not publish that publicly, but they do have a number, a threshold as we call it, internally. And during negotiations here in Canada, they use a threshold internally. They will say to the manufacturers of new medicines, you are charging us $100,000 per quality adjusted life year. We need to get that down to a more reasonable number, right? So that is saying, considering all medicines collectively, we have a common price. We have a common willingness to pay for a unit of health, a quality adjusted life year that applies to all medicines. And the dynamics are different when you think in that way. Let's begin with the independent pricing. And I'm going to go over these quite quickly. This is a long slide deck, and we only have about 30 minutes. But the model that I published, this framework, inevitably there are a number of assumptions. So what we've done here is we've simplified things for the main framework, and then later in the paper, we kind of relax these one at a time. What happens if we weaken this assumption and so on. So we're going to keep things simple in terms of the perspective. We're going to assume that all we care about is the health of the population, this narrow healthcare payer perspective. We're just looking at the costs that fall on the healthcare system. As I said earlier, a broader perspective, societal perspective, could be adopted, and it does have implications for how you price medicines. We've assumed that the objective of the payer is to improve population health outcomes, right, consistent with that perspective. You might have a payer that doesn't want to just improve population health outcomes. They actually want to start weighting population health outcomes. They might, what we call equity weighting. They might say that the health of an individual with a very severe disease, maybe we're going to value an improvement in their health more than a patient with a less serious disease. Okay, and this does happen. In the UK right now, the government agency, NICE, has an explicit equity weight. They are willing to pay more for treatments that are aimed at patients with more severe diseases. Right? They're also willing to pay a lot more for treatments for rare diseases. Okay, highly specialized technologies is the term they use. Okay, so they have a different willingness to pay the different medicines. Okay, but we're going to keep things simple and assume that there's only a single willingness to pay. We just want to try and improve population health outcomes rather than focus on the distribution of those health outcomes. We're going to assume that medicines have one indication. Of course, in practice, they often have many indications with different effectiveness in those indications, which might lead to different fair prices across indications. We can talk about that later, but it does complicate things. Patients are homogeneous. Well, yeah, in practice, when you've got heterogeneity across patients, the incremental benefit could be different across these patients, and you might want to split patients into subgroups and talk about the price for each subgroup. We're going to keep things simple. Medicines have marginal net budget impact. What does that mean in plain English? It means that we're not considering medicines that have an enormous disproportionate impact on the healthcare budget. You do get some of them. So like the hepatitis C treatments that came out about a decade ago. when they came out, there was a lot of concern that even though these are very effective treatments, the budget impact would be so enormous that it would start displacing a lot of activities within our budget. It might not be affordable to actually pay for these. Those are some of the concerns about at that time. So what we would say as economists is that they have a non-marginal budget impact. They would start displacing not just a few activities, but quite a lot if we try to pay for them in one go. You need to deal with them in a different way. Think about how you would roll those treatments out. We'll assume there's a single constrained budget. Of course, in practice, you might have silos in your budgets that causes inefficiencies. Let's strip that away. You can see how rapidly this problem can, how complicated this can get. So in order to try and make any progress, you need to make some simplifying assumptions, see where you get, and then start relaxing those assumptions to sort of get the more complex picture. We're going to assume manufacturers are not charities. They incur costs of production. They won't supply at a loss. Of course, again, in the developing world, maybe they would, right? So we're talking about a healthcare system here where they will not supply unless it's profitable to do so. And to keep things simple, we'll assume that there's a single minimum price. We call it a reserve price at which a manufacturer will supply the health system. Again, it could be a lot more complicated. They might be willing to enter into a risk-sharing agreement with the public system. It might depend on whether any rebates are confidential. So again, the reality can get more complicated. And given the effectiveness of a medicine, for any given reserve price, there's what we call a reserve ISA. An ISA is an incremental cost effectiveness ratio. It's the standard way of talking about whether a medicine is cost effective, right? So every economic evaluation that you see from Canada's Drug Agency will have an incremental cost effectiveness ratio. And it's basically telling you how much extra do you need to pay for every additional unit of benefit this medicine provides. The most common unit of benefit being the quality adjusted life year. So you might read in a report, the ISA for this medicine is $50,000 per quality adjusted life year, per QALY. And what that means is this is a medicine that costs more than what we're doing now. It provides more benefits than what we're doing now. And those, if you take those additional costs and those additional benefits and divide one by the other, it's an additional $50,000 for every additional quality adjusted life year. That's what the ISA is. And so we can think of what the reserve ISA would be. If we tried to push the price down below that, well, then you're not meeting the reserve price and they'll take their ball and walk away and not supply the healthcare system. Okay. We'll also assume that manufacturers are protected by a time-limited patent monopoly. Okay, so that's true here in Canada. That what it means is that they are able to raise prices above marginal cost. So what you learn in Econ 101 about competitive markets doesn't apply if there's a monopoly provider of the medicine. Okay, but of course patents are time limited. So there's these dynamic issues, right? What about later when the price falls, when there's generic competition? So many different assumptions. We've tried to keep things simple at the beginning. And as I said, later on in the paper, I do sort of relax these one by one, see what happens. Now, again, those of you who've taken an economics course, you know the very first thing we talk about, a demand curve, supply curve. Demand is just how much are we willing to pay? How much are consumers willing to pay for something? And the supply curve is about how much are producers, what's the minimum price they're willing to accept in order to supply something. So we can start off by thinking about the demand curve. What would the demand curve be for a medicine from the point of view of a public payer? And if we assume that that payer wants to improve the health of the population, then the most that they should be willing to pay for that medicine is the point at which the health gain from that medicine is exactly offset by that expected health loss, because we'd have spent the money on something else. Right? If the price is lower, fantastic. We gain more than we lose. But the absolute maximum that they should be willing to pay is the point where the health gain equals that health loss, and there's no population health gain. Okay. Now, what is that point? Right? That price is the point at which this ISA, incremental cost effectiveness ratio, equals the marginal cost of producing a unit of health within the health system. Okay, and I know this isn't an economics audience, so I'll explain that a little bit further. So given your healthcare budget, imagine what would happen if you started at zero and expanded your healthcare budget. You're just starting off with your public health system. You put a few $1 million into it. There's a small amount. What's the first thing you'd buy? Right? Maybe you'd build a hospital, maybe not, maybe just a small clinic when you're starting off, right? And you'd eventually buy all the things that we sort of take for granted in our public healthcare system. But you'd start with the low-hanging fruit. You'd start with the really obvious things. And then as your budget increases, you have the sort of the luxury to spend your money on things that are still effective, but they provide less and less kind of marginal benefit, right? So healthcare systems in Canada and other wealthy countries, those last few dollars that we're spending within our public health system, they're improving the lives of patients, but less so than the first few dollars did, right? And so you would expect in countries with much lower GDP per capita, have much lower public health spending, they're getting a lot more bang for the buck from the last few dollars that they spend than Canada would. And the United States, I would expect, would get even less marginal benefit than Canada, right? And so what we're interested in here is not the average cost of producing a QALY across the health system. We're interested in what is the marginal cost, the last dollar you spent, right? Those last few dollars. What's the marginal cost of producing a quality adjusted life year? And this is a really difficult question to answer, right? So within our public health system, as it stands, with all the inefficiencies that we've got in our system, okay, how many more dollars would you need to add to our budget in order to create one additional good quality year of life, right? And it's difficult because this isn't something, it's not like you can go into Shoppers Drug Mart and just buy a quality adjusted year of life, right? This isn't a market thing, right? This is something where we call it a shadow price, right? Because there's no market price for this, right? You add extra dollars to the budget and you're able to reduce a waiting list here, right? Maybe add a doctor there. And some patients will have better quality of life, longer life, and you'll gain an additional year of life. That's the question. How much does it cost? And if we can estimate this, then we can plot that demand curve for a medicine. We can say, okay, how much are we willing to pay for this medicine? Well, we know how much health we're going to forego, and so we know what the maximum is that we should be willing to pay. But this is a really difficult thing to estimate, right? You need an empirical estimate of how much it costs to produce one quality adjusted life year within your healthcare system. And it's something which health economists across the world have actually done. They've actually tried to estimate in a number of countries. So this was a paper that I was a co-author on several years ago, 2022. And this did a review of all the studies that had been published around the world up until that point. And there were only 4 of them that were conducted in developed countries with public healthcare systems, right? So if we're interested in public healthcare in Canada, these are the most relevant studies. It's not all the studies. I can talk about the others if anyone's interested, but the 4 studies that are most relevant. So the first one was done at the University of York in England, and this was the first of its kind. You can see the title is Methods for the Estimation of the National Institute of Health and Care Excellence Cost Effectiveness Threshold. So what is the most that the UK's body that negotiates the prices of medicines, that does health technology assessment, what is the most that they should be willing to pay, right? On the idea that you shouldn't be willing to pay more than you're losing, right? And they estimated that it's around about £13,000 for a QALY. So given the state of the UK's National Health Service at that time, in 2008, given the state of the system, with inefficiencies taken into account, they estimated that adding £13,000 to the budget would produce one additional quality adjusted life year, and taking £13,000 away would reduce population health by one quality adjusted life year. Okay. They actually found that it was different across different disease areas. It's a higher number in cancer, it's lower in mental health, but on average, it's about £13,000. Now, why is that important? Because if you've got a constrained budget and you spend money on a new medicine, you're taking money away from other activities. And so the estimate is for every £13,000 you take away from other activities, you'll lose one QALY. But if this new medicine provides more than one QALY for that £13,000, well, that's a good thing. We're going to gain more health than we lose. But if it provides less than one QALY, you'd expect to lose more health than you gain. That's the logic behind this. Spain did a similar thing. So there was a university there that published, these are all peer-reviewed studies, 25,000 euro per QALY, which is a little bit higher than the UK estimate. Australia, 28,000 Australian dollars. And then Sweden, so 180,000 Swedish krona. And of course, these are all in different currencies. They're all for different healthcare systems. They all use slightly different methods. But if you were to try and convert them, and I was involved in some work with Canada's drug agency several years ago, back in 2020, we tried to convert these into Canadian dollars because at the time there was no Canadian research to look at. And you know, they're all below 50,000. The median is about 30,000, but there's quite a range here. And ideally, we'd have our own Canadian research. Would we expect the Canadian estimate to be similar to these, or more like the US? It's possible that in Canada it would be a bit higher than these. There was a US study, not included in this review, but that came later, that estimated that within private insurance in the US, it's more like $100,000, right? Which is not surprising. Okay, so where would Canadian public health fit in? Is it more like public health in Australia, or more like private health in the US, right? In terms of its marginal efficiency, and we don't know the answer, right? So we need to do that empirical work in Canada. I'm just aware of the time, so I'm going to just skip over this quickly, or I'll just answer it myself. So basically, if it was $30,000 per QALY, right, in Alberta, so every $30,000 that we spend on new medicines within Alberta, if it did result in us foregoing one QALY because we could have spent it expanding primary care access, reducing hospital waiting lists, what would the impact be if we reimbursed a new medicine with an incremental cost effectiveness ratio of 15,000? Well, 15,000 would be great, right? If we're only paying $15,000 a QALY, then for every 30,000 we spend on this new medicine, we gain 2 QALYs, and we only lose 1 elsewhere. So we're ahead, right? We're gaining a QALY of population health. If the ISA of the medicine's 30,000, well, then every 30,000 you spend on the medicine, you gain a QALY. Every additional 30,000, you gain a QALY, but you're also losing a QALY elsewhere. So you're treading water in terms of population health. And if it's $60,000, well, then every $60,000 extra you spend on this medicine, you gain 1 QALY, 1 quality adjusted year of life, but you displace 2, right? So we're actually diminishing population health, right? So again, very, very simplistic. That 30,000 is an estimate. We need to have a much better estimate for Canada. But that's the way that as a health economist, I think about what the maximum price that we should be paying for a medicine is, right? We shouldn't be paying such a high price that it displaces, that it reduces population health. But you know what? We can argue with that. We can say, well, hang on a minute, maybe certain individuals, we should value their health more than others. Okay, so maybe in some cases we would be willing to pay more. What about the supply curve very quickly? So that's just the manufacturer's minimum willingness to accept, right? So what's the lowest price they'll accept? This is really challenging to plot because manufacturers keep a lot of this information confidential, right? They don't want to disclose what their costs are of producing medicines. Even if we knew it, there's things like international reference pricing that complicate things. Even if it's profitable to supply medicine in Canada, a manufacturer might say, well, hang on a minute, I don't want to supply at that low price in Canada because other countries might look at it and say, well, we want a low price as well. And Canada's a relatively small market compared to that other country. So maybe it would reduce their global profits by doing that, right? So things can get quite complicated. And what we have now in Canada is we have an agency that negotiates prices across Canada, the PCPA, the Pan-Canadian Pharmaceutical Alliance. They will negotiate prices on behalf of the provinces and territories. And what they will often do is negotiate a confidential rebate. So we pay the high list price, but we're actually secretly getting a rebate that we don't disclose. And so that is one way of mitigating the reference pricing issue, right? Companies can have a high list price in Canada. Other countries go, oh, Canada's paying a high price. Actually, we're getting rebates through the back door. So what really matters is the final price after the rebates, which is often confidential. The key result, though, here is that usually there's a range of possible fair prices in which the consumer surplus, meaning the population health gain in this model, is positive. Right? The price is below that estimate of the health opportunity cost, $30,000 per QALY, whatever it turns out to be. Price is below that, so we're gaining population health, but it's also above the marginal costs faced by the manufacturer, so they make a profit. Okay, and the reason this is important is there are some health economists who've said all we need to do is estimate that health opportunity cost, $30,000, and set that as our cost effectiveness threshold, right? And the challenge with that, and I'm aware of the time, so I'll skip some of the slides to get into this in more detail. The challenge with that is that manufacturers will very likely be strategic in how they price their medicines, right? So if you say, I am willing to pay $30,000 for a QALY, or $50,000, which is the number that we usually use in Canada right now, what would you do as a manufacturer if you're profit maximizing? Would you price your medicine so that it's $40,000 per QALY? If the payer's willing to pay $50,000, you're leaving money on the table, right? That's not a smart thing to do. So you would price this at $50,000, And I can tell you, they do the economic modeling internally to figure out how they can price this, right? But here's the thing: in Canada, even if they price it way above 50,000, we don't say no. We just enter into a negotiation. So what will usually happen in Canada is the prices will be much higher than this, right? If you look at any report from Canada's drug agency for new medicines, it is very rare to see that at the list price, the incremental cost effectiveness ratio is below $50,000 per quality. It's very rare. Often it's in the hundreds of thousands, sometimes over $1 million per quality, right? Extremely high prices, but we don't necessarily pay those. There's then a confidential negotiation and we get rebates, right? Now, do we negotiate down to the point where the ISA is 50,000? We don't know because it's confidential. But here's the thing: even if we did negotiate down to the point where we are only paying 30,000, 50,000 per quality, whatever that estimate of the health opportunity cost is, the problem with that is that every quality we gain is exactly displaced by one foregone. So in terms of population health, we're actually not improving the health of the population. And so what I would say is, well, hang on a minute, we're making an investment in this new technology as a public health system, right? Sometimes a risky investment, because sometimes the evidence around whether this medicine is effective is quite uncertain. Sometimes these clinical trials are not very large, they're not very long, for good reasons sometimes, but there's uncertainty as to the long-term effectiveness. So surely we shouldn't be making an investment with public dollars where there's no expected rate of return, where we expect the benefit to be exactly offset by the opportunity cost, right? Surely the public would expect that we get at least a small population health improvement when we do this, right? So what my framework advocates for is having a price that is lower than that estimate of the health opportunity cost in order to ensure that there is a population health gain when we pay for new medicines. But you need to be careful, because if you push it too low, manufacturers might take their board and leave if it's not profitable. So then the question is, what's a fair share of that economic surplus, right? We talk about return on investment, and we usually think of return on investment from the point of view of the manufacturer, right? They will often say, price is too low, we can't go that low, we're not getting a sufficient return on investment. And that is true, because the manufacturers need to raise capital from the markets in order to invest in the trials, developing the medicine. That's true. It's entirely fair for them to get a fair return on investment. But we don't often think of the public payer making an investment, because when they pay for a medicine, there are dollars that they're putting into it that could be used to improve the health of the public, right? Through expanding primary care, reducing waiting lists. They're making an investment in terms of population health, a risky investment, and we should expect there to be a positive return on that, right, in the years to come. Okay, I'm going to skip some of these slides here. In terms of pricing medicines collectively, I just said a few minutes ago, there's going to be a range of possible prices. That range is going to be different for every medicine. For a medicine that is very effective, you can have a higher price at which the ISA equals a given threshold, right? So the more effective the medicine, the higher the price you can charge. So having this sort of framework actually provides an incentive to manufacturers to produce the most effective medicines possible, because they can then charge a higher price, right? But in practice, payers often have, as I said earlier, a willingness to pay. They will say, "I'm willing to pay $50,000 per quality." Do you want me to wrap up in the next 2 minutes? I'm looking at the air. Okay. Yeah, I can see the time. We only have about 12 minutes. 2 minutes. So in practice, they will sometimes announce publicly, as happens in the UK, we're willing to pay £20,000 per quality, £30,000. That's announced publicly, or implicitly. In Canada, it's often implicit. And so what my framework gets into is, well, how should you set that? How should you determine your willingness to pay? And I'm just going to skip over this section because we don't really have too much time. But I go through an example which illustrates that if you have a common price that's too low, that's actually bad for both the payers and for the manufacturers. If it's too low, then medicine just won't be supplied because they're not profitable. Nobody wins if you do that. As you raise your willingness to pay, first of all, you get medicines that are now profitable, they're supplied, and that's a good thing. But there is a counterfact. There's two counteracting forces here. As you keep raising your willingness to pay, two things happen. One is that more medicines get supplied, which is a good thing. But the negative is, as you raise your price, your willingness to pay, those medicines that would have been supplied anyway at the lower willingness to pay will now be priced up, right? Because manufacturers are strategic. So you've got to deal with these two counteracting forces. You raise your willingness to pay, more medicines will be supplied, but they will be supplied at higher price, which causes more displacement, which reduces population health. And so what is the point at which population health is maximized? And again, I'm aware that we're short of time, but I can talk about more if anyone has any questions. But the point where it's maximized is going to be somewhere below that estimate of health opportunity cost. So I would expect it to be below $30,000 for QALY in Canada. But in order to say that for definite, we'd need to do some empirical work in Canada. So I'm just going to skip on this. I've talked about return on investment already. And what I argue is that there needs to be a return on investment for both sides, right? It's reasonable for the payer to expect a positive rate of return because they're making a risky investment when they adopt new medicines. Further considerations, dynamic pricing, what happens when prices fall post-patent? I would argue that we actually should model that and we should take that into account, and it would result in higher prices in the short term because we're going to get a discount in the future. But we shouldn't pay such a high price that over the lifetime of the medicine, we expect population health to be diminished. There are some medicines with no fair price, orphan drugs. It might be that it's just impossible to price this at a point where we improve population health without it being unprofitable. And we need to think about what we do about that. My approach would be to maybe cross-subsidize that from other medicines. Blockbuster drugs, maybe we can get enough consumer surplus from them to cross-subsidize those medicines, orphan drugs that are not profitable. But we need to talk about those things. I'm not going to get into this, but the framework does get into, what if there's multiple indications? What if there's multiple budget silos, all the rest of that? So in summary, it's a framework for the determination of fair prices for medicines. It tries to strike a balance between the interests of patients and the interests of manufacturers. And by patients, it's not just the patients who receive the medicine, but all patients within the public health system, because when we spend a lot of money on a medicine, you could have used those dollars to reduce waiting lists, to expand primary care access, to do any number of other things that would improve the lives of other patients. Okay, so in my framework, all patients get a voice. Okay, but we need to balance the interests of patients with the interests of manufacturers. Okay, and there's clearly, it's difficult to do that, right? The interests don't align between the two. I'm just going to skip over this because we're out of time, and I would like to give time for questions. Here's a few possible discussion points.
Thank you.
Yeah.
So we do have time for a few questions. That's why I want to finish your talk a little bit early. So we have one question here online. So I've seen estimates of cost per QALY for dialysis of nearly $100,000 in Canada. Can that be used as the estimate of societal willingness to pay?
That's a fantastic question. So there are things that we pay for within our health system that would cost $100,000 or even more, right? And where it gets very difficult is that there are also very likely things that we don't currently pay for that cost a lot less than $100,000 per QALY, right? So there's inefficiencies, if you like, right? We're probably not completely rational in maximizing population health. Maybe it's inappropriate to say not rational. Maybe we have a different objective that we're actually not trying to maximize population health. And for whatever reason, we prioritize dialysis, but not other things. There's all sorts, if you want to get into the politics of it, right? Things like safe injection sites, the economics are incredibly favorable of those things. But of course, the politics isn't always, right? And so there are things where you can really improve the health of the public. And yet maybe we're reluctant to pay for it. So we need to be very careful about sort of identifying certain things that we pay for, where that's $100,000. So surely we should be willing to pay more than, or at least $100,000 for any medicine. Well, the problem is that we need to look at, when we pay for a medicine, what is it we're giving up? And right now we have very long waiting times in hospitals. 1 in 5 Canadians don't have access to a family doctor. Those are things that we could be spending our money on. I suspect it's far less than $100,000 per QALY. That's where you need to do the empirical work, right? To look at, the sort of things we would spend money on at the margin, how much do they cost? And the work in other countries, as I said, in other developed countries with public health systems is closer to $30,000 per QALY.
Okay, and another question is, so in Canada here, how do you calculate your QALY?
How do you calculate QALY? So for those who've not encountered QALYs before, it's the standard measure of health outcome that's used in health economics. It's not without its controversies, but it's been around 40 years, and there's a reason for that, because there's alternatives, but very often they're worse. So a QALY is a combination of two things: length of life and quality of life. Right. The idea is that it's good to live longer, and it's also good to live in quality of life. And there's good quality of life. There's two dimensions here. And so the QALY takes into account both. How do you trade those things off? How would you trade off a shorter life in good health versus a longer life in poor health? The public are asked to do various exercises to trade these things off. So the QALY takes into account the preferences of society in trading off length of life, quality of life. So that's how we do it in Canada.
Okay, and so another question here. Thank you for the talk. Okay, can you comment on Canada's time-limited patent laws?
Yeah.
And are these in need of adjustment, especially with the resultant migration of small biopharmaceutical companies to other countries and elsewhere?
That's a fantastic. I mean, we're going to spend the whole hour talking about that. In 30 seconds, I think it's appropriate to have a time-limited patent. It provides an incentive to manufacturers to do that risky research. I think it's appropriate. You need to give manufacturers a return on their investment. And so that's fine. We can argue about the exact length of it, whether it should be extended a little bit, shortened a little bit. One thing I would say is that in granting a time-limited patent, we are imposing an artificial monopoly here, right? The government is saying, hey, you get an artificial monopoly for this length of time. And when the government brought in the Patent Act in 1987, I believe it was, at the time it was recognized that, hey, this could result in market behavior that we might not like, right? Exploitative behavior. You're talking about a life-saving medicine. You've now got the patent, the monopoly for it. You could put the price up as high as you want. So they set up the federal agency that limits, that regulates patented drug prices, so the Patented Medicines Prices Review Board. But the way in which they regulate has not been substantially reformed since the 1980s. There was an effort to do this about 8 years ago, but it didn't get very far, right? And I've written, and others have written, on how poor that regulation is. And so what it means is that our regulation of patented medicine prices is not effective. The prices are too high. And that's why we need to have these negotiations to get rebates, right? So there's no issue with, in my opinion, with having the time limited patent, but we need to have better regulation at the federal level.
So I think we're pretty much good for time. I just want to first state that anyone in our department, actually, just one last question before we go.
Yeah.
When do most of these people come to the health economics? Do they come later on? Or for example,
Yeah.
can people come in early? Is it better to come see someone like you early on?
So this is a fantastic question. So it used to be late on. It used to be that manufacturer would develop a medicine, basic scientists would work, they'd spend the best years of their life developing a medicine, and then later on they'd price it, and a health economist like me would go, sorry, it's not cost effective, right? Increasingly, they will come early on. They will talk to the health economists early on while the medicines are being at the early stages. And a health economist can say, hang on a minute, you have an idea here, but actually there's so many competitors in this particular area. You would need to get this level of effectiveness, or you'd have to keep the price down to this point in order for this to be economical, right? And so in some cases, that means maybe don't proceed with that particular medicine, that particular avenue. Maybe spend your R&D budget somewhere else where there's a lot more headroom, if you like. There's fewer comparators. You could charge a higher price. And so that's really important, actually. So engage early on. There's an increasing number of consultancies and others that can help biopharma companies at the early stages decide whether it's worth investing or not. So things are improving a lot. It's both late on and early on now.
Okay. So last question from Minu, is it appropriate to compare ICERs evaluated from a societal perspective to the commonly applied threshold from a system government payer perspective?
Short answer, because I know I have about 10 seconds here, no. The short answer, you need to be extremely careful. So as I mentioned earlier, in thinking of what that threshold should be for how much we're willing to pay for a medicine, what really matters is what else could you do with those dollars? You know, expand primary care access, reduce waiting lists. How much health are you foregoing as a result of spending it here? The moment you expand your perspective to a societal perspective, and you're saying it's not just health, it's also healthy people are more productive, right? And also kids, if you give, autism treatment, maybe they're better in school, right? And so there's educational benefits, right? So the benefits can extend beyond health. So there's a lot of pressure, particularly from the pharmaceutical industry, for agencies like CDA in Canada to expand their perspective because the medicines have greater value from a broader perspective. The challenge is that we still have a constrained budget. Those dollars could be spent expanding primary care access, and primary care also has these additional benefits. If you expand primary care access, it's not just the health benefits, it's the productivity benefits, right? There's all sorts of benefits you'd get from doing that. So the value of the opportunity cost is also greater. And that means you need a lower cost per quality threshold, right? So if you expand your perspective, yes, your medicines will now usually have lower ICEs. There's evidence from the States, about 25% lower. But you should also have a lower cost effectiveness threshold. And some medicines will be more cost effective, those that have really substantial productivity benefits. Others might be less cost effective. Your cancer medicine for patients at the very end of life that gives them an extra month or two, how much more productivity is that patient likely to get if they're in their 70s or 80s at the end of life versus spending the money on expanding primary care access for people in their 30s and 40s? How much productivity benefit would you get from that? You could well find that expanding the perspective results in your cancer medicine appearing less cost effective. That could well happen. But it wouldn't if you didn't change your threshold, right? So yeah, I know we're out of time. Thanks very much.
Thank you.
Yeah.
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 Okay. So thank you
Yeah.
very much.
Thanks very much. Thank you.